Okay.
Thank you so much.
So we'll just begin in 1 more minute. Okay, we can. I think we can begin now.
Yeah.
And I'll just introduce. So, hello everyone, and welcome to another session of CAPSOC's clinical events. We have here Dr. Sorello John and Mrs. Maurer Suze. Yes, and they've been kind enough to come and talk to us about their cancer care experience, and we will sort of incorporate a bit of narrative medicine into this conversation, so it would help first years think about their sort of patient interactions, and also the second years getting their essay done. So I think at the end we'll also cover some impacts of COVID-19 on cancer care, which is very important. So if you don't mind, whichever of our patients could maybe talk and begin their journey.
Just before, Amir, I'm just going to say I'm going to keep an eye on all the questions and stuff as well, guys. So if you do have any questions, please do send it through to us, and we will we will actually then mention it to both the Dr. Sorel and Suzanne as well. Thank you so much, guys. Appreciate it.
Just call me John.
Thank you. It's an honor. Thank you, John.
Right. Do you want to go first, John?
Yeah. Okay. Are you asking me a question, or do you want me to give you some background on my cancer?
Yes, please, if you could give some background of your journey and the cancer. Yes.
Well, it was a total surprise. 13 years ago, I was having some paroxysmal atrial fibrillation, and as part of the workup, the cardiologist wanted to do some liver function tests, and they were slightly abnormal. So I went for a liver scan, and I'm glibly having the liver looked at by the radiologist when we both see this cricket ball tumour in my left kidney, which was a mega shock, actually, possibly because I knew what it was when I saw it. And I had an nephrectomy, and it was a stage 2 papillary cell carcinoma, and I'm very, very fortunate that it was picked up before any symptoms, because I was well, apart from the AF. I had the tumour removed, and was surprised at the psychological impact, to be honest. I was off work for 2 months only. I was working as a specialist occupational physician then, although I have been a GP as well. And went back to work and found it quite difficult to interact with patients, because especially patients that you were seeing with cancer, relating it to oneself. In fact, the very first patient I saw when I went back to work, it was at the Open University, actually, Susie, had got recurrent carcinoma of the kidney after 14 years, and that really cheered me up, as you can imagine. And I found my relationship with other people with cancer was much better after that as a doctor, certainly much more empathetic. Hence my involvement with cancer support groups now, and with the MKCPP.
Yes, I think I could just chip in here on what John was saying. That one thing that I found is I'm not medically qualified, obviously. I'm a crazy author, is it, in the daytime. What is, I think, most difficult, and speaking to other cancer patients, the most difficult and heartbreaking moment is when you are first diagnosed with cancer, and you have all these people surrounding you, clinicians, nurses, doctors, everybody saying, oh yeah, we know how you feel, and you think, actually, no, you don't, unless you've been there yourself. Is that right? Does that ring a bell, John? And it's probably one of the worst moments of the cancer journey, because you feel desperately, desperately lonely. And of course, that's where support groups can be fantastic in keeping you going and keeping your spirits going during the worst parts of the journey, which is one of the reasons why John runs a support group, and I'm a member of one or two myself.
Yeah, and of course, what do patients do when that happens? And I did it as well, except I used Scholar Google. You go and look it up, don't you? And read all the negative bits and not the positive bits. And I should have been objective, but I wasn't. I couldn't be objective at all. I was very lucky because Mr. Anjim is a very, very good at explaining things. The urology consultant. I think he's just retired, hasn't he?
Yes,
Or
I think
he's certainly stepped down. Yeah, was phenomenally good at helping. My experience in hospital wasn't very good, but we'll talk about that in a minute.
I was just
Okay,
I was wondering if I could ask just a question just before we move on. Yourself, John, and based on the point that you made, Susan, and the fact that you know, you said that you were experiencing it from a non-medically trained point of view, which is probably what the majority of cases are. But John, how would you say that your experience differed in terms of the fact that you were medically trained? How did you view it differently from someone that wasn't medically trained?
I knew too much.
Hmm.
I knew too much, but couldn't look at it in an objective and balanced way. But now that people have access to Google, that possibly is becoming a problem with patients too. I don't know.
Yeah, still good old Dr. Google.
When I was at your stage, we didn't even have ultrasound. So I'm 73 now. Seriously, there was no ultrasound when I was a first-year medical student. Or CT or MRI.
Wow.
so you mentioned that the urologist explained things well, and we know that obviously with you, they sort of, what language did they use to explain things, because you have a background?
He was very, very good, actually. I should think he explained it very much as he would have done it to a patient. He didn't use technical terms. He explained, drew a picture. We weren't expecting the tumour to be quite as big as it was. I had to have a debate about whether I was going to have it done laparoscopically or by open surgery. So being old-fashioned, I elected for open surgery. And actually, he said when he did it, he was glad we did because the tumour was so big.
Yeah. Okay. Yes. So what happened next? The surgery, and then did you receive any chemotherapy?
Well, hardest thing was the 3.5-week wait for surgery. Trying to carry on working. It was my 60th birthday celebration, and all my children, I have 3 sons and their wives, came to what was going to be a birthday celebration party, and it turned out to be the day before I went in for the surgery. It was more like a wake, to be honest, this dinner. And I think I was more concerned about the reaction of the family than I was to my own feelings about the tumour. My wife and the 3 kids were very hit by it. The middle son particularly was really floored. And I think that probably preoccupied me more than the actual worry about surgery.
Yes.
A lot of people say that that when they're first diagnosed, their main concern is how their family, their spouse and their children are going to react. And they're more worried about that than they're worried about themselves.
Yeah.
So what sort of support strategies did you use to counter these impacts?
That was quite difficult because as an occupational physician, I was working on my own and didn't have immediate colleagues to talk to.
Yes.
1 or 2 friends that I had a word with. My GP was very good, and my GP was one of my previous. I was his trainer when I was in general practice, so we had a relatively good relationship, and he was very supportive. But I don't think the family picked it up. I mean, of course, the boys went all back to their various places around the United Kingdom after the party, all very worried. And in fact, one of them drove down to see me in hospital twice from Nottingham because he was worried. But I don't know what support they had apart from each other, wife and husband. But as my wife particularly, I think probably took the burden hardest because she had very little support once I'd gone into hospital, apart from sons on the phone.
Yes.
We didn't have, I suppose I had a bit of support from the vicar and a couple of people in the village. I live in a village where I was the GP for 20 years. And then I went off and did other things. So there was that sort of slightly interesting mixture of friendships. But I had a couple of good friends, and I had one friend who'd had the same thing happen to him when he was in his 30s. He was in our drama group, and he was very helpful too, because of course he'd been there, done that, and got the ticket.
So, talking about the psychological impact on yourself, could you maybe expand on that a bit more?
Anxiety. Not. I didn't get depressed about it. I was a rather realistic, really. What will be. More anxious about what would be if it was going to be negative. If I was going to recur, because there was not much around for renal treatment 13 years ago that worked. Really, particularly papillary cells. Papillary cells, quite a rare form of renal tumor, not the commonest. And it was really the Watsonists of the house. We moved house 4 months after I'd had this thing taken out. My middle son was getting married 4 months afterwards, and there were all those worries about, was I going to screw up the wedding arrangements, which were going to be in Vienna? Was I going to screw up? I'd just started this occupational health job. I'd just taken on the business, having left general practice and having got myself specialistly qualified. There was all that issues. I was more anxious and worried about that and tidying ends up than I was about my own, what happened to me, really. But I did have a faith which helped, I think, in terms of what happened to me.
Yeah. John, may I just ask a medical question in terms of the cancer? So, can everyone hear me properly? I was just wondering, when you were initially diagnosed, what stage was the cancer progression at, and what type of surgery did you have? Could you expand on it, maybe?
Oh, Mr. Angim thought it was still contained within the capsule on the scan and CT scan, and the plan was a radical nephrectomy, which he did through a lateral approach, a horizontal lateral scar, and he said he was surprised, and in fact it was just bursting out of the capsule. He said when he took it out, he was surprised it was bigger than it looked on the scan.
Wow.
So yeah.
And
so did you have?
Sorry, please go ahead. No, please go ahead. Okay.
Yeah. So go on.
So did you when you went through the surgical procedure, did you actually did it take a long time for you to recover and get back?
I had a very stormy week in hospital. I was a little bit cross with the junior staff, who I hardly ever saw. The junior doctors were not very good, I have to say. This is Milton Keynes. I meant the nursing staff were exemplary, but for example, I didn't have a post-operative blood test for 4 days until I asked why they hadn't checked my renal function, which is bad, really. And I got an ileus as well, so which didn't help. So I felt like death warmed up for about 2 or 3 days. Once I got home, I was readmitted after 2 weeks because I had a slight recurrence of this partial obstruction again and was vomiting with abdominal pain, and that settled. But the first time I had to be dripped and sucked. Mr. Angin and I had a big disagreement in the ward about dripping and sucking, because I don't think it's an accepted practice these days. And in my day, it was the first thing you did was to drip and suck for partial ileus. And he was very cross when he came in and saw the nasogastric tube down, which I'd spent half the night fighting to get. But he and I are great mates now.
Wonderful.
So, did you have any other treatments except the surgery for your cancer?
No, 3 monthly CTs for, I can't remember whether it was a year, then 6 monthly, and then that went on for 5 years of scanning. And each time, of course, it was clear, nothing else at all. No. In those days, there were not the radiotherapy was of no use at all. I think they might have changed their practice slightly now. And there was pretty much not much chemotherapy. I know there are some specific drugs now for renal cancer, but there weren't then. And
did you have any sort of risk factors or any family history of
overweight?
Renal cancers?
Overweight. I had a polycystic kidney,
okay,
which we knew about from an earlier scan for something else. but whether that was linked to the papillary cells, it was never accepted that it was the cause. But obviously one of the cysts, the tumour was in one of the big cysts, I think.
Okay. I think we have a question, I think. So the question is, you mentioned that it was difficult having doctors say, I understand how you're feeling when you were diagnosed. What advice would you have for us to conduct these consultations in the future appropriately? I think that was the question for Suzanne, but obviously you could.
I think from my perspective, and I tried to practice this after this tumour as much as I could. I had a great privilege in occupational medicine and having half-hour appointments with patients or with people. And I looked after fire services, and I saw quite a bit of renal cancer in the fire service for one reason or another. You have time to talk it through with people and answer questions. My GP wouldn't have known for about a week and a half if I hadn't have phoned him up and told him. So he couldn't support me. Obviously, the hospital. There was, of course, the clinical specialist nurse that was able to give support, but she disappeared after the first 2 days, and I had no further contact with her. So I don't know what happened, but I don't think that's normal. Normally, the specialist nurse that's attached to you when you're being prepped for the operation and things keeps in contact, is on the end of a phone to answer your questions. She weren't for me. Yeah. I completely.
Yeah, sorry. You mentioned that your GP wasn't aware of this. So how was the communication between
bearing in mind 13 years ago, the electronic connections were not the same as they are now.
Yes.
You know, it would have been a letter in the post, not an electronic communication. Okay. They're much better now, and I have to say, I think that the whole being involved with the cancer services in Milton Keynes, I think Milton Keynes is now exceedingly good at communication for cancer. And that comes out in my cancer support groups. My cancer support group has patients from both Northampton and Milton Keynes. And there are some significant differences in communication between the two. It's interesting. And I think the setup in Milton Keynes, especially with the cancer centre now, is very good. And communication is the key bit of it.
So, Suzanne, do you want to maybe give your opinion on that, please?
On certainly, yes, communication. Communication still has a lot of holes in it in the NHS. But now I think at the hospital end with Milton Keynes, certainly things have improved a lot. And it's the further down the line, really, between, as I mentioned early on, I think, was between the hospital and the GP practices. That can leave certain things to be desired. It's a little bit the case that they live in their own little worlds and that they don't actually realise that all part of the same medical healing function. But we're working as a kind of liaison group. We're working on we have temporary hold. Hope it's temporary. And we're working on that in the community, and that has created quite a lot of interest, hasn't it, John? Elsewhere in the NHS, because that's not something that a lot of hospital areas or trusts don't have groups like ours at all, or if they are, they tend more to be support groups, or they tend to be very much led by the clinical nurse specialists with a few patients around drinking tea and saying yes and no. It's not on the scale we do it, or with the independence that we do it. But Macmillan, amongst other large organisations, are very interested in what we do, and they watch us. They come to our meetings and think, why can't we think local like they do, which is something they should learn to do. But yes, I think at the time of John, funny enough, John's surgery was around about the time that I was having surgery or treatment particularly for my urological cancer, which was a bladder cancer. But I ended up with surgery at Northampton, not at Milton Keynes for that. I had Milton Keynes for the breast cancer.
Can we just get your opinion on, you mentioned that doctors, when you diagnosed, and doctors and sort of medical professionals told you that they understand you. how else would they have approached this that would make you feel better?
I think it's between a rock and a hard place. It's if they haven't experienced it themselves, there's no way they can know how it feels. I don't know, John. You as a GP are probably the best one to answer that, because yeah, I mean, would you say that would it have helped one of your patients? Obviously, if you'd had cancer yourself, then you're ideally suited to discuss it with them. But
a little bit, yes. I think the biggest problem is time, having time. I've had a couple of circumstances in the village, because the other advantage is that we're in a village with a village practice, and so there's more unity between everybody than maybe in a bigger city. But I've had 2 or 3 patients who've been diagnosed with cancer and have had very good discussions with their specialist teams in terms of treatment options, and this is particularly true of perhaps prostate cancer. I've had a man with prostate cancer who'd been through it quite thoroughly with his specialist, but he needed more time to go over the ideas, and I was able to go and see him and spend an hour and a half with him, bouncing off ideas, not directing him, not giving anybody, just letting him talk about it, and perhaps just nudging him off some inaccuracies in his picking up of the information. You ain't got time for that in clinical practice, to be honest.
Yeah,
but the nearest you can get to that, the better.
And the irony there too is that not only do you not have time in clinical practice to give them the time that anybody would need to work through, but also with patients, if you've just given them the shock of the diagnosis, they need time, more time than they would otherwise, to absorb the information and come to terms with it. And you'll find that you might say 5 sentences to them, but only 1 or 2 will stick, and the rest they won't even penetrate. That's why it's often a good idea to get patients to bring somebody with them to write things down, so that they then go home and digest it.
I would agree with that, and also there's a tendency now to give you lots of literature when you're going for procedures and so forth. But you have to read it, and I mean, even I struggled to read the paperwork when I was worried about the diagnosis and things. And it's that having that opportunity to contact somebody to talk through things you're not happy about or unsure about. Clearly, that can't necessarily be the lead clinician. That's where I think these specialist cancer nurses come into their own if they're doing it properly. But they should then share that information if there's any worry about a particular aspect with the clinician. That's my feeling.
Yes. And Suzanne, could you maybe describe your journey so we can have...
Okay, well, I had recurrent episodes of cystitis, bacterial infection-related cystitis, since the age of 12. It ran in the female side of my family. Eventually, when I was, well, in my 50s anyway, it got worse and worse, and eventually I was diagnosed with a papillary tumor of the bladder, which was removed through a rigid cystoscopy. And I went on for several years, going every so often for what we called a poke and peek, which was either a rigid cystoscopy or a flexible cystoscopy. And I, funnily enough, was treated by the same urological team as John was, but I had Mr. Andrews was my consultant then, and still is. And eventually there were small recurs of papillary tumor, and eventually it turned to carcinoma in situ, which was, without anesthetic or even a sedative. I'd have a flexible cystoscopy, and they would be lasering off this sort of flat tumor. And they said, this might be a bit uncomfortable. And Henry Andrews and I always used to have a laugh about that. So they decided that it was time to have the BCG installations, which I had various different courses of so many weeks, and then maintenance courses, which went on, and I was keying razor blades for about 7 years, I think it was, from the first diagnosis. And eventually I was transferred to Northampton, where they tried me on a course of BCG with interferon, This is going back to, 10 years ago. And that didn't happen, so the consultant up there was no longer there. It was a guy called Mr. Bell. Remember Mr. Bell, John? Richard
No,
Bell?
after my, oh yes, actually I do, yeah.
He said, a very funny story. I shouldn't really use humour here, but I do write a lot of humour. He gave me a long list of all the things he was going to remove from my lower abdomen, and he said, well, of course, we'll give you a complete hysterectomy, so that's the uterus and the fallopian tubes and the cervix, and we'll take the bladder and the blah, 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 and the anterior wall of your vagina, which would lead to another funny story, but we'll leave that another day. And while he was reeling all these things off, I said, tell you what, while you're up there, you couldn't do a bit of liposuction as well, could you? And he didn't think that was in the least bit funny. But the Macmillan nurse was falling off her chair. Anyway, so a couple of weeks later, I was in there, had surgery. I was in for nearly a month because I got a kidney infection and various other little problems. And in the meantime, in 2005, 2003, 4, I'd lost my father, not to cancer, and I lost my mother to lung cancer. And I was bringing up a young son on my own, with my mother living at home, and she eventually became paraplegic. She had a lung cancer, ironically, and never had smoked, with mets all over the place, eventually to up the spinal cord and into the brain. And I was dealing with all this stuff, and people say there's no real clinical evidence that stress has extreme stress has a connection with cancer. But you ask people what anecdotal evidence there is, and they'll say, it's how much do you want? And I'm convinced that my cancers were connected to the stress of losing my parents and having all these different stresses coming in at the same time. So a year after my mother died, I was diagnosed with a breast cancer, which was whilst I was having BCG treatments for the bladder cancer, but both were primaries. I had a mastectomy and chemotherapy for 6 months, and that was okay. I didn't have to have radiotherapy. And that, the last episode of clearing up the cancer was in 2010 when I had the bladder removed, and fingers crossed, I'm all right to this day. But I was having had such a hard whack of cancer over those few years. I thought it would be nice to put something back into the community as a patient, and obviously not as a clinician. But it's useful, as you're finding out today, to have both sides of that story, both from somebody who is medically qualified and somebody who isn't. Because actually, I don't think there are as many variants between the two as you might expect. Because as John was saying earlier on, he didn't probably react. Well, I'm quite sure you didn't react to your own news of cancer, cancer diagnosis, as if it had been somebody else or a patient. It's a completely different sensation. So it's an interesting dynamic, isn't it? That how does somebody who is medically qualified react? And it's likely to be more as a human being than as a trained medic.
Can I just ask you about the difficulties you had? Sorry, you said you were raising your son, and sort of how the cancer affected that.
Well, it was difficult. I mean, I tell you what, the best tool I had in my toolbox was humour in those days, and I was bald, so I had a wig, and I used to be at the old Macmillan unit at the hospital. We didn't have the cancer centre then. And I'd be saying to the girls, come on, hurry up, get my chemo finished. I've got to go and meet the school bus. And then I'd have all these boys who were sort of 12, 13, 14, and they would grab my wig and take it off my head and play with it, trying it on. So I'd be driving a car full of kids home and old as a that helped because everybody took it lightly and saw the funny side. And, the 12-year-old had just lost his grandmother who lived with us, and his grandfather the year before that. I think he's turned out pretty sane considering, and I wanted to try and take the sort of nastiness away as much as I could. And he's got a very similar sense of humour to mine, so he came out of it relatively unscathed, I think. But I didn't.
So much.
I think a lot of it was the humour and keeping everybody laughing and everything. That put even more of a strain on me because I had to manufacture it.
Suzanne,
I think that.
please go ahead.
Oh, sorry, you go, Ash.
I was just wondering if if you could kindly expand on your experience in chemotherapy, and you mentioned that you went through chemotherapy obviously during an extensive period of time, and some of the side effects and the symptoms, and were they managed properly as you were having them through the NHS, or do you think that more should have been done, or anything in that regard? I would be grateful if you could expand on it.
I was incredibly lucky. Several of the nurses, nurse specialists, ANPs, who gave me my chemotherapy are still there. And of course, now we work together with the MKCPP. We became like a family. It was wonderful. There was in the unit, there was a lady, blind lady, who was going through treatment, same program as me. And she used to come in with this golden retriever seeing eye dog. And we'd all come out of there having had our chemotherapy at the hospital, covered in dog hair, which was quite amusing. But the staff there were absolutely fantastic. I was very lucky. My side effects were minimal. I lost my hair, obviously, but apart from that, and feeling a little bit off, but I didn't have any problems with nausea or diarrhea or any of the other side effects that were common at the time, although now there's quite a lot you can have in terms of medication to counteract those sound effects. No, I was incredibly lucky. I think one of the funny things or ironic things about it is that when you finish your chemotherapy, which went on for 6 months, you feel kind of lost. You feel you've been tied up with this family and you all got to know each other really well, and you're thrown together with a group of people under those sort of circumstances. There's an immediate, very strong bonding that you wouldn't have if you just met them in a bus stop. Yeah. And I've actually stayed friends with a couple of the people I met there, and also in Northampton Hospital, funnily enough. It's a bonding experience, unfortunate though it is, which I think amongst the medical profession, there's very strong bonding too.
Could I just say, from our cancer support group, where we have developed this bond between people that come to it. A lot of them are breast cancer, because obviously that's one of the more common cancers. Harder to get men to come along with their cancers, interestingly, mostly women. But boy, does the group get hit if somebody dies because of their tumours recurred or they've progressed to death. That really knocks the group for six. I mean, at least they're there to support each other. But that can be a problem when you've made quite a lot of mates of people you've been sharing treatment with too, isn't it?
Yeah, I think one thing that our secretary, she has secondary breast cancer, and she is a member of a secondary breast cancer support group. And I haven't obviously taken part in that because it's not my remit. But she said it's a very different form of support that takes place with secondaries, because obviously with you have a secondary, you know that you'll be around for some time, but that you're not going to get better. That is it's becoming more interesting now that so many treatments have been evolving, particularly with breast cancer, that keep patients going for a number of years, many years sometimes, with a reasonably good quality of life. But there's still that knowledge that you're not going to get better, and that's a very hard one to. It's not one that I can currently, at least, guide you on, and I hope it isn't the case for John either. But we do have, as I say, one of our group who is in that position, and I'm sure would be willing to talk to you guys about it at some point.
Thank you so much. Just have a question. Going back to,
I think Cameron had a question beforehand.
It was just a short thing before we go on to the questions from in the chat. It was you mentioned the fact that you used humor to get through it, Suze. I think it's very interesting in the fact that in relating it to the narrative medicine course that we've been doing as well, and you know, having to analyze someone else's story in a way that you see how they coped through everything, and I think it's very interesting in that they do say that, you know, positive mental attitude and laughter can sometimes be the best form of medicine for you. And it sounds like such a cliche and nonsense for, you know, when you're supposed to be studying how things properly work and why medicines are the best way forward, etc. But do you really think there is some truth in that, you know, a positive attitude and an approach and having those people around you are really such a key part to getting better? Because I mean, I think looking at my patient's story personally, her positive attitude and her husband's support has definitely been a major factor in her condition. So I was just wondering if you had any comments on that.
Chemically speaking, the answer is no. There's no way. I really don't think. A lot of people say, "Oh, if you have a positive mental attitude, that'll cure your cancer." That's bullshit. But what it will do is to mean that you get through it a lot more easily, and from that point of view, that will add to your toolbox of things to make you feel better overall. Whether there's any actual effect on the cancer on the cancer cells, I don't know. I suspect not.
I actually think that there is a tiny bit of evidence that mental well-being and reduction of stress does help, actually, but it's not a very strong research, but there is some support for that. To go back to when I was looking after 4 fire services, the great thing about firemen is that they work together in a team, and they're in that team together for a long time. And boy, if one of those got a serious illness, not necessarily just cancer, having those blokes around that knew them very well, a couple of girls as well, but in my day there weren't that many women firefighters, really gave them that positivity to get through it. They weren't on their own. They had their mates supporting them. I had a fairly bad car crash in Cambridge about 3 years after I left the fire service as their medical advisor. Had to be cut out of a car by a group of firefighters that recognised me, and they all turned up at the bloody hospital afterwards to see how I was, and that was 3 years after I'd been working for them. And that sort of support when you've got down with cancer or you're having cancer treatment, I think is a positive thing that helps. And although the evidence is not strong, I do think it makes a difference.
Well, I could well stand corrected there. But the one thing you have to be careful of, certainly in my position, is that although I found that humor helped me and my family get through it, not everybody has a sense of humor at all about the same thing, and you have to be extremely careful. A lot of patients will take, John, you will have seen this, take the attitude of, I don't want to know anything technical, just get rid of it. I just don't want to, and they pretend that it's not there. They just go into total denial. So if you start making jokes about playing with wigs and things, they don't think it's funny at all. But it's you know, it depends on the individual. And yeah, the support of the team, I think, is that. Yeah, I mean that would be very. I didn't have a team because I work on my own, and my family. My mother was very ill herself. So, but yes, in those circumstances, it must be wonderful to have that.
So may I just ask the questions that our members asked. So Noah asked that I understand that the idea of mastectomy can be very daunting to many women and is often not an easy choice to make despite its clear benefits, and can have a big psychological impact if it is done. Is it something that you struggled with?
No, I didn't. In fact, my mother had breast cancer, and she had the same attitude. If mastectomy was going to mean I didn't. In my mother's case, she didn't have to have chemotherapy. She said, right, cut it off. That's it. I never want to see it again. I was quite happy to have a mastectomy. I didn't have reconstruction largely because at the time, reconstruction surgery was 10 times more painful and awkward and unpleasant than the surgery for mastectomy. So I thought, no, you know, I was wrong side of 50. I wasn't going to start breastfeeding children again. So I said, let's have it up. Nowadays, obviously, there are much kinder and more effective methods for women. Younger women, I can well understand why they should want to do it. But I lost a very close friend who had triple negative breast cancer, which is a nasty one to get because it's not hormone driven. And she was an actress and minor Z-list celebrity. And she said, oh, my boobs are part of my job, you know, I have to look. And she wasted a whole year trying to find a consultant in London who would do a lumpectomy. And of course, A, with triple negative, and B, having farted around, frankly, for so long, it got out of control and she was dead in a year. Now, that's not to say that if she had gone straight for a mastectomy, as she had been advised to, the same outcome wouldn't have happened, but it could have. And I thought, no, it's still too dangerous, potentially dangerous a disease to take liberties with. I think maybe in a generation or two, I'm sure cancer treatment will be quite different and more effective, but I wasn't prepared to take a chance on maybe a little bit being left. I was stage 2, but it was I think it was a 2.5 centimeter tumor in the left breast. So, you know, it wasn't exactly a small one.
Did you have the sort of the same attitude toward your other parts of the treatment? And did you comply fully with the treatment, or were you unsure sometimes?
No. I mean, I by that time I'd learned enough about treatment and cancer, and I think I had already been shanghaied into joining the MKCPP while I was lying on a gurney with the urology nurse, instilling this BCG into my bladder with my legs in the air, and she said, "Oh, the MKCPP are looking for a volunteer member. You are interested, aren't you?" And it was Angela. I can't remember her last name now. Finn. Do you remember her, John? Yeah. Angela Finn. So yeah, I got involved and learned. One thing I did find helpful was learning as much as I could about what was wrong with me. Other people, like I just said, they say, I don't want to know any of this technical stuff. Just take it away and get rid of it. But I found it's because you feel so, you feel very, one of the scary bits for a patient who's not medically trained, and possibly who is that you suddenly feel totally out of control of your life. And you've got to hand over control of your life to clinicians. But the more that I know about it, the more that I can absorb about it, the more in control I felt of my own destiny, if you like. That's probably not nonsense. But it made me feel better to actually know. And that's one of the worst parts of the diagnosis bit at the beginning, is the fact that you know absolutely nothing about what's going to happen to you. Yeah.
Yeah, just a question for John. So with these patients that don't want to know anything about their treatment or their disease, do you think that affects compliance? As you know, you can talk about the both sides.
No, and I think they're quite uncommon too. I think most people, we have a good network in how we run it now, that if somebody's newly diagnosed with breast cancer, the GPs will actually come through the group to get somebody else who's been there, done that, to link up with them, to talk to them before the surgery. And not so easy with the men. Men don't want to talk. Men are a real problem. They don't want to talk about it, I find. And it is quite difficult, I think, if they just want to get on with it, or take the doctor straight, get on with it, do it, don't want to talk about it, want to forget about it afterwards, you know, don't want to talk about it in the pub. Those sort of things is very common in the man, I think. But no, otherwise not.
John,
yeah, sorry, go ahead, Yash. Sorry.
Thank you so much. I was wondering, in terms of treatment, this is a medical opinion. So cancer is patient's performance status plays a big role when it comes to treatments of cancers.
Sorry, I missed that.
Hello, can you hear me?
Yeah, I just missed one word.
So patient's performance status plays a big role when it comes to the treatment of cancers.
Mm.
I was wondering, in terms of what the system that we have in NHS, do you think it's an efficient system to treat patients? Obviously, some of the targeting therapies aren't available because they are much more expensive. And we are moving to a place where cancer is becoming more of a tailored kind of therapy. So do you think the system that we have at the moment implemented in NHS is able to compete with that, or do you think it should be more efficient?
I think the NHS has improved astronomically, certainly since I was a hospital doctor in the 1970s. That was a long time ago. I think in the last 10 years, there's been phenomenal improvements. I'm mega impressed with how Milton Keynes integrate what they're doing and try to improve all the time. I'm very fortunate. I now sit as a patient representative on a couple of the internal validation meetings, and that there's a drive all the time for doing better. I don't think it's equal throughout the NHS. And I think that's the problem. And I think one of the things the COVID-19 may have done was that for the first time ever, the NHS has been working as a unit rather than as little bits, sometimes competing with each other. And if we can carry that forward, it'll be even better. Yeah. I mean, I left the NHS in 1994 to go into private occupational medicine. But what I've seen in some private things, I would stick with the NHS. With all its
warts and all, yes.
Yeah.
Thank you so much.
I remember going. I had began with my cystoscopies at a private clinic, which is just over the fence from the hospital, the Saxon Clinic, and the consultant there, who'd been a consultant, he said, "I don't know why you're paying for it. Just go over the road." And when I went to the NHS facility, the endoscopy suite was like chalk and cheese from what I'd seen in the private place. Whereas the private place expected James Robertson Justice to come walking through, with a big beard and shouting. Whereas in the hospital, I thought, oh look, it's a video, it's a video. I can watch what they're doing on the television screen. The NHS. I mean, I tell you what, I frankly wouldn't go cheapo private with a broken fingernail unless I was extremely rich and could go to one of those big private hospitals in London, but otherwise no, NHS all every time.
Thank you so much. Thank you.
We have another question. Asha says, how do you think the experience with the cancers has impacted your writing? I think that's targeted to Suzanne.
Impacted what? Sorry?
Writing.
Your writing.
I actually wrote an ebook called How to Smile Through Cancer, which was a collection of anecdotes from a blog that I wrote, and also stories from other people who experienced, again, funny stories. And that did very well. I think it's not just my writing, it's my whole life, really. When you a diagnosis of cancer, and I'm sure you've heard this many times before, it makes you reevaluate a lot of things in your life, not just your job. It makes you reassess your priorities. Some things which you previously would have thought are very important, you suddenly think, actually, you know what, they're not important anymore. And that can actually be very good for you, as long as you survive the cancer. It's very therapeutic, and it makes you appreciative of the better things in life, the more important things in life, rather than chase your tail trying to keep up with the masses. Would you agree with that, John? With that?
I think so, yes. It helped me in making my decision to, I would agree with that, yes. Yes, it does change your approach to life completely, and live more for that. As I say, I have a faith as well, which probably helped. It probably reinforced my faith, actually. Some people would find it hard, but I've found it reinforced my faith. I must say, I didn't have... Sorry. Any more questions? Right, before I ramble, have you got more questions?
No, that's it.
No, I was I was very disappointed with the junior doctors 13 years ago because they spent virtually zilch time at the bed talking to you post-operatively. They used to look at all the notes, look at all the records, the nurses' records and observations. And if you were lucky, it was good morning, you're all right, fine, and move on. There was no, is there anything you want to ask me? Have you got any concerns? And the consultant only did a round a couple of times a week, so the registrar was perhaps the key person. He was a little bit better, but the junior doctors were very little. How the hell they could report on how I was, apart from the paperwork, I don't know. And I think that was a fault. In my day as a junior doctor, all right, that was a very long time ago. We were indoctrinated about it. I worked for a professor of surgery when I was a houseman, who wouldn't let you prescribe a night sedation the night before an operation. If somebody couldn't sleep, the nurses had to call the junior doctor out of bed to go up and discuss with the patient why they couldn't sleep and what their worries were. And it was documented in the nurse's records. And the consultant the next day would say, why was this drug prescribed to help this patient sleep? Give me the nurse's records to see that you've been up and discussed it with them. And so, yeah, that's where I learned good communication. At the time, I thought it was a bloody pain getting out of bed in the middle of the night to go and see them. But in retrospect, it worked. It eased people's worries.
And do you think that has improved? Because we have this this sort of concept called ICE, and it includes expectations of the patient, concerns of the patient. And we are really encouraged to use it. I think the students that are with us now, some of us didn't see the point behind ICE. And now that you've mentioned that, is actually very important to ask about the patient's concerns and know their view instead of sort of looking at the patient as just the pathology.
Yeah, the guy that insisted on this we regard him as a bit of a pain, but it taught me a lot, because you weren't allowed in those days. Night sedation was phenobarbital, would you believe? And you weren't allowed to do any of that without it being documented. You spent at least 15 minutes at the patient's bedside discussing with them why they couldn't sleep. It didn't matter that the main City of London post office was next door and was making the row of a mainline station. You had to document that they were not too worried about answer their questions about their operation the next day. And that taught me an enormous amount, which is why I think I was a little bit disappointed with the doctors when I was in hospital, because I'd not been in hospital before as a patient before my cancer, really. I have since been in Oxford twice in the cardiac side for my AF, and the system's much better. The junior doctors are very much better now than they were that particular time 13 years ago in Milton Keynes.
Can we just move on to the effects of COVID-19 on the patients that you know, or anyone?
Amir, just before we go on to that, can I ask a question? Just
yes,
with
yes,
relation to that, you mentioned like the junior doctors weren't so great back then, and there are some things that leave a lot to be desired, etc., in certain areas of the NHS. But having experienced it, both of you as a patient, and John, you as a patient and a clinician as well, what
Sorry,
do you feel?
I can pick it up.
No, that's all right. It's okay. Coming through this COVID-19 scenario and pandemic, do you feel that there is much to be learned in terms of, like you said, working as a unit, etc.? And if so, what kind of things do you think are to be learned from it?
I think that it's probably a bit early to generalize, but my feeling from being an observer outside the system now is that we became very restricted. We went down to local commissioning groups that commissioned the work. It made a degree of competitiveness between hospitals. The GPs were inundated with bureaucracy, and they couldn't get on with doing the job of the patient. In my day, when I first came into general practice, I could refer anybody to any hospital in the country and the funding was central, and it worked. And I thought that introducing this competitive element actually created more bureaucratic levels of things, paperwork to fill in, things to do about this, that, and the other, you know, and shortages and rationing in different things in different areas of postcode, basically, wasn't it? In some aspects of things that were done because of the way that the thing was financed. And when it'll never be enough money for the NHS because it's a bottomless pit. But yes, and I do think that maybe as long as we don't forget this last 7 or 8 weeks and we look at the positive sides of how things work together and carry that forward into the proper practice, it'll improve the NHS enormously. But whether it will or whether the politicians will go back to their own usual selves, I have no idea.
Yeah, so it's something I sincerely hope too, because I mean the NHS was becoming, from an administrative point of view, was becoming very top heavy, and that was the lack of administrative skills, shall I say, could well have been impinging on money that could otherwise have been directed into clinical activities. And that's speaking as because I'm a writer, but I have a background in marketing and business, basically. And some of the things I've seen and heard in the past in the NHS on the administrative side have made my teeth curl, frankly. But I think now the lessons are being learned, and as John says, that this experience where everybody had to snap to it and get on with it, and never mind the politics, internal politics, will have been a very, very strong lesson for them all.
Yes.
Not the clinicians. The clinicians were working together properly to begin with, but it's the back office.
Yeah.
It needed the shake up.
Bringing in a military style thing helped as well, actually, to get organisations to get past bureaucratic blockages. Going back to the COVID and cancer, I've had 1 or 2 people that have been a little concerned that their chemo has been delayed because of the worry about them being immunosuppressed with the virus. And they've been slightly anxious about what impact that would have on their outcome. But it's been very well explained, both of the patients that I had discussions with, it had been very well explained by the teams why they weren't doing it, and they fully appreciated that the risk of getting COVID was greater than the risk of perhaps delaying their chemo for a few weeks. But
there's been a bit of a hangover from that now, that people who have symptoms that they worry might indicate cancer haven't wanted to go to their GPs or to be referred to the hospital because they're saying, oh, well, they're so busy with COVID-19 that it's unfair to take up their time because I've got a hard lump in my left breast. But that's, and certainly in our case, the cancer service has been running, an emergency, all the emergency elements of every department have been running pretty much normally all the way through. But we're lucky because we're a district general hospital. I think it's managed small enough and therefore manageable enough that this can happen. Where you can see these such administrative bungles becoming a major problem is in the much bigger hospitals, where you don't have one end of the building doesn't know what's going on in the other end of the building. That's
so do you think the NHS?
That's just my own observation as somebody who's been in business. So,
do you think the NHS is doing enough for patients that are worried that they have, cancers? Because I found this statistic that it says around 2,000 patients who have cancer will go undiagnosed because of the situation. And do you think they're educating the public enough and doing enough for them to come forward and
well, certainly the news programs are doing a lot, aren't they? It's being brought up all the time on the main news channels, and worry about it. The newspapers are full of it. I think there's been people have been scared to go to their GPs because of this thing. We've got in our village practice, they queue outside the window to collect that. It's a dispensing practice. They queue outside the window to get their pills. If you have a blood test, you go around the back and go through the fire exit under the fire escape. and this creates a slight negativity about going to see the doctor. But they're Zooming, they're having online consultations. They're very quick and very rapid at answering and dealing with. If you ring up and ask to speak to the doctor, they'll ring you back within 2 hours in this village practice. But there has been a certain reticence to get involved or to go to hospital because of will I catch it? I think it's getting less so now that we are on the downward slope, hopefully with no backup kick.
Yeah, well, I'm running the our own group on Facebook, MK Cancer Patient Partnership Group, if you want to have a look. And I'm also a reviewer and broadcaster on one called Milton Keynes Beating Coronavirus. And I've been making sure that there's plenty on there at a local level, like only Milton Keynes catchment. For heaven's sake, if you're worried, call your doctor. In fact, you're liable to speak to your doctor a lot faster now than you would have done before the pandemic, because you can get, as John said, you can get to speak to your doctor in a couple of hours rather than wait 3 weeks for an appointment.
Yeah. There are still occasional problems with communication. I had a phone call yesterday. My phone number is on the Macmillan website as the contact for the local group. And I had a phone call from Portugal yesterday from a gentleman whose mother was 92 and had just been discharged from hospital with what he thought was cancer of the stomach. And they live in Northamptonshire. And he wasn't being able to get any information about it at all. And he said, can you give me a contact to get some information? I just don't know how to find out how my mother is. I mean, all right, the exceptional circumstances, but I think I managed to persuade the local practice to ring him up in Portugal. But yeah, but I know there's consent issues and confidentiality issues that come into it. But it was an interesting. When I knew I was doing this today, I thought,
Thank you so much. I think we have another question, if you don't mind. I'm just going to ask it. So Noha asks, we've been taught that introducing the idea of competition between different hospitals was aimed at encouraging each unit's best performance with its available resources. Do you believe it has achieved this or any other positive outcome?
I'll leave that one to you, John.
Mostly no. It may have brought the bad ones up a bit in standard. But no, because it never really worked. The principle was good, but the practice was appalling. And I just think it became it was a rationing process, really. And the distribution of the funds was perhaps not fair, which didn't help between the different CCGs. But no, the principle was good, but in practice, it didn't. I don't think it worked.
I think it's absolute lunacy, isn't it? Sorry, Tony, go ahead.
It generated such a lot of bureaucracy in the practices. My GP, I spoke to the person that took over from me when I left the practice. I spoke to him the day before yesterday, and and asked him how he was coping with the circumstances, and he said, well, the first 2 or 3 weeks it was wonderful. The CCG were all muddled up. We got no memos, no bureaucracy, no things to do, no 10-page documents to read every day. He says, but they've got organized now and it's all piling back on us. There's extra work, we can't get on with the medicine. And I think that sums it up.
This competitive element, I worked for some years doing conference speech writing and things for ICL Computers, which was a bit like IBM, only the British lot. They then became something else and got eaten up by a Japanese firm. But they had this management policy of putting departments of the company, and there are thousands and thousands of employees, pitting them against each other in performance terms to see who could do best. And I actually attended meetings where we were putting conferences together with several of these different departments, where these people were coming to blows. Literally, they were coming, this booted and suited executives, throwing fists, doing that at each other, because of the policy, the management policy. I thought this was probably one of the reasons why the company didn't last very long, but not the only reason. But it's a cheap trick of management to do that competition, because it's a cheap and cheerful way, they think, of creating team spirit and getting people to work together, which is exactly the opposite of what it achieves.
There's an absolutely magnificent programme on BBC 4 at 10 o'clock last night, the title of which I've forgotten, which is about a number of little playlets written in the lockdown situation, so that all the people are on Zoom, and there's a little scenario of a company meeting of about 14 or 15 people from the company, and the person running the meeting has obviously got to meet a production target to have so many of these things produced today, and they can't because of all the things to do with COVID, like supply chains and all the rest of it, and people off sick. And it is an absolutely hilarious. And one by one, the manager, who obviously has got to get this target or she's going to lose her bonus, is locking people out of the Zoom meeting to shut them up when they're telling all the reasons why it can't be done. Well worth watching if you've got time on iPlayer.
Yeah.
Thank you so much. If there are no other questions, I think we can maybe.
Humour, talking about humour, I mentioned a very good friend of mine from the Drama Society who had an nephrectomy for cancer as well. He and I played the Ugly Sisters in Cinderella, and in the dressing room when we were putting our costumes on, the rest of the cast saw 2 nephrectomy scars, and we had a real laugh about it for the rest of the show. 2 kidneys between the 2 sisters.
Oh dear.
Thank you so much.
Have you read This Is Going to Hurt by what's his name? Adam Kay?
Yeah. Yeah.
That's one of the funniest things I've read in a long time. His experiences as a hospital doctor.
Yeah. I mean, I felt very sad because it wasn't good when I was a junior doctor, but it weren't that bad.
No, well,
No.
maybe there's a bit of exaggeration there. But,
I'm not sure about that.
Right.
Okay.
Any other questions?
No, I don't think we have any other questions. No, that's it. Yeah, I think then we can conclude the session now. And thank you so much for your time. And yes, it has been a very amazing experience.
Thank you guys so much. As we said, because of the lockdown, we don't get to have enough clinical experience, and this was, extremely kind of you to provide us with this opportunity, and we're forever grateful. And hopefully, the experiences that you bestowed on us today in this session, the new generation of doctors that are hopefully going to come out of Buckingham, will take them into consideration, and that's going to help them improve. So thank you so much.
Yeah, so good luck with training.
Good luck, yes.
Thank you so much.
Thank you so much.
Okay.
Bye.
Bye-bye to all of you that we've not been able to